Hello everyone, and welcome back to another USMLE 101 video. This time we're going to be talking about presentation skills, how to present the case during internal medicine rounds, and how to be as comprehensive as possible but as efficient as possible. So before I start, there is a presentation template. You can see it down below in the description below the like button, and you can open that up as we talk during the video, and I will have some stuff here pop up as well, so you'll be able to follow along. But it's great if you do have it in hand or if you have it on a separate screen, so you'll be able to follow easily. Before I start as well, I want to preface that this is my own opinion. It's not something that is set in stone. So please feel free to change it up a little bit, tailor it towards your own attending or your own hospital work or your own workflow. And if you gain at least just one or two points from what I'm talking about that helps you during your presentation, that would be fantastic. And feel free to share that video with anybody who's starting residency or who wants to improve their presentation skills. I think that would help tremendously. All right, so without further ado, I'm going to get started right away. So the presentation itself is going to be divided into four main parts. The first part, which is probably the hardest actually to get right, is the subjective part. The other part is going to be the objective part, and then the assessment, and then plan. So it's called SOAP. Coincidentally, that's sometimes what the same way people put in their notes, but that's a separate thing that we're going to talk about at a different time. So let's start with the subjective part. So subjective part is where you're going to be saying the patient name, the patient kind of story or complaint or issues that have happened so far up until the patient is seen this morning. So for example, you're going to be saying this is Mr. John Doe. He is a 55-year-old gentleman with a past medical history of hypertension, diabetes, etc., who presented to the hospital last night with a complaint of chest pain while he was shoveling snow, and he was found to have an NSTEMI and was admitted to the hospital, admitted to the regular floors. That's kind of one way to do it. And then you can go on and say, Mr. John came to the hospital into the ED, complained of chest pain. His physical exam at the time was found to have, and you can say just pertinent positives. So don't go a lot into details, but at least the main positive things. Let's say he had like a murmur. That's a big thing to say. Lower extremity edema, big thing to say, and so forth. But I wouldn't go and say that abdomen was normal and all the other stuff that were normal. And then you can say the labs were drawn and they found to have, and you can say what the positive things on the labs are. I would be as precise again into the labs as much as possible. So I wouldn't say all the labs, I wouldn't say all the values, but just what exactly is pertinent. And then say the imaging as well, same way. And then you can say in the ED, those are the interventions that were done. He was given a liter of NS, for example. He was given antibiotics. He was given, Lasix, whatever it is that were done. Any consultations that were done as well, just to kind of mention what exactly happened. So you're telling a story and trying to get people up to speed of what exactly the patient is at the moment. So again, be as precise as possible, but as comprehensive as possible. And it's a balance. And again, I don't think it's that easy to do. So it's something that you will need to get a lot of feedback on from your attending, from your senior resident. So this part will need a lot of practice to get right. So after that, you're gonna get to the part where the patient got admitted to the hospital, to your floor, for example, and then you have to mention what the overnight events are. Sometimes there are nothing, so you can say nothing happened overnight, or you can say the patient again complained of chest pain overnight, and those are the stuff that happened, or what the night team did, and so forth. And then finally, you're gonna say this morning patient was seen and examined at the bedside, and he or she complained of this and that, and you can mention what the complaints are. At that part, you are going to be done with the subjective things. And again, as I said, it's kind of the most difficult part to get right. And it's the part that you're going to be getting a lot of feedback on. The next part is going to be the objective part. And this is your chance to mention all the kind of data that you're going to be using to kind of deduce what the diagnoses are or the problems of the patient are. So it's important to be thorough and to be systematic. I think the system or the kind of the way that I'm going to be saying that, like going about it in this order, I think is important. You can change a couple things, but mainly going in that order will help a lot. So the first thing you're going to be saying is the vitals. So you can say it in whatever order you want, but the main thing is that you want to give trends. It's important to see how the patient was before the actual value that we have now. So for example, if you have a patient's blood pressure now is 160 over 70. If the patient all night was 220 and now it's 160, that's different than a patient who has been in the 90s, systolic, and then all of a sudden now it's 160. So you see the difference here. So you have to give kind of like a range. The patient's blood pressure was ranging from this and that, and now the blood pressure is this. Same for heart rate. And same for temperature and everything else in the vitals. For the temperature, you have to say the T max, which is the max temperature the patient has had. And it kind of helps to say what exactly is the temperature right now as well. So I would say temperature range was from 36.9 to a T max of 38.9. Current temperature is 37.8. So now we're done with the vitals. We're going to go to the next one, which is respiratory. So respiratory can be the O2 that you are giving the patient. So you can say that the patient is on 2-liter nasal cannula, or you can say the patient is on the ventilator, and you can say all the vent stuff. I'm not going to go into details on that specifically, but you can say the mode, or you can see what the settings are and so forth. And this is like in the ICU setting. And you can say what the saturations are after that intervention. So 2-liter nasal cannula, patient saturating 99%. Or patient is on room air, saturating 99%, and so forth. The third part is going to be your exam. So you can say, as much as possible, as long as it is relevant. I wouldn't go into, head to toe like a med student would, unless this is what your attending requires. I think the most important part is to be, again, concise and to the point, but also be scientific. So I wouldn't just, say random things in different organs. So be systematic still, and try to be thorough as much as possible. The most important part of the patient is also old patient. I think it's important to say what the difference is on the exam today than it is yesterday. Same way as we talked about in the vitals, for example. So if the patient has lower extremity edema, today it's +1, yesterday was like +3. That's different than it is +1 today, and yesterday he didn't have any lower extremity edema. So just be mindful of that. And then afterwards, if you're in the ICU, then you're going to be talking about the kind of the drips that the patient is on. So you can say what are the drips in general, but highlight the vasopressors and the sedatives that the patient is on. So vasopressors is probably best to review it with the nurse. If the nurse is with you during rounds, then maybe she or he can actually give those values. But please make sure that you actually do have the current ones. And then the next is going to be the sedatives, same idea. So if you're going to say the patient is on propofol, on Fent, let's say propofol 50 or Fent, 75, whatever it is that the patient is on, and then again, the nurse can help you out. The next is going to be the IV fluids that the patient is on. So if the patient is on an S, you can just say what it is. So LR, for example, at 75 ml per hour. That's really important. And then you can say the feeds. So feeds can be a little tricky sometimes, but generally you have to say if the patient is on a regular diet, a modified diet, like something that is a little bit mushed or something that is, level 1, level 2 and stuff like that. You can just get that from the chart. It's pretty easy. Or you can say that the patient is on 2 feeds, where you have to mention what exactly are those 2 feeds, what is the rate that the patient is on at the moment. TPN can also be one of those things that you mention on the 2 feeds. I'm sorry, on the feeds part. The next part is going to be the I/O, so ins and out. This is really, really important in the ICU and CCU settings, or any case that is a cardiac case, especially if you're diuresing the patient. So you want to see how much the patient has intake-wise, so whatever water they drank or whatever fluid they gave them, or how much output from urine output or emesis, or if they're getting output from a drain or anything like that. It's really important to know what it is and what net positive or negative they are. So that would be in the last 24 hours, they are net positive of 1 liter, for example, so they got more than they peed out, or the other way around. And you can say through the hospitalization as well. So since the patient was hospitalized, patient is negative 16 liters, and that would be pretty significant, again, if you're diuresing the patient or the patient is critical and in the ICU or CCU setting. The next part is going to be the labs. So you're going to be saying all the labs that the patient had that is current to today. I think it's important sometimes to also give that trend. So my main example would be a hemoglobin of 8. So that can be of from somebody yesterday had a hemoglobin of 12. That's a pretty significant drop. Or you can say, let's say another patient still 8, but had a hemoglobin of 8.2. So it's pretty much the same value. So it doesn't really change my perspective here. So once you're done with all the labs, then you're going to say the microbiology, which is your urine analysis, your cultures, urine culture, blood culture, or any respiratory panel or GI panel and all these things. Next, you're going to be talking about imaging, and I think it's really important when it comes to imaging to actually open the image and take a look at it yourself and do your own interpretation, especially if it's a chest X-ray or something you're going to have to deal with yourself, versus like an MRI, which might be a little bit difficult, but still try to do your own interpretations. And then you can mention, obviously, what was found on the real report as well in comparison. Other things that you can add to that part is maybe like, echocardiogram, some miscellaneous things as well afterwards, like, EKG or any procedure that the patient did, like an upper endoscopy, and what are the findings of these things at the end of that kind of objective part. All right, so we did the subjective part. We kind of understood what exactly is going on with the patient-wise, what's his story or her story, what's the complaint, what's the exam, all the data that we found so far on the labs and everything. Now we can get that data and then try to do an assessment and plan. So with the assessment, you're going to give kind of like a one-liner of what's going on with the patient, what are the active problems. So this can be really a good idea to go problem by problem in the kind of floor setting. If you are in an ICU setting or a CCU setting, sometimes it's a better idea to go system by system, like head to toe. So you can talk about the neural, you can talk about cardiac, lung or pulmonary and so forth, and you just go system by system and kind of see exactly what the abnormalities are and what exactly is your assessment of those systems. And then based on that, then you can go ahead and talk about your plan. So you go through all the medications that the patient is on, what exactly you want to change, what exactly you want to add to it. And again, you can go problem by problem. So let's say patient is here because of DVT. So you're going to start anticoagulation, or you're going to switch the anticoagulation from IV to oral. And that's where you get to make your changes, make your suggestions, and see exactly how you're going to progress with the plan. The last part here in the plan itself, and I think that this applies to anybody regardless of what's going on with the patient, are things you should not forget. So those are going to be your DVT prophylaxis, your GI prophylaxis, if it applies to the patient. You're going to address any tubes, drains, IVs, or any central lines, or anything that the patient has, and whether or not they need it to stay or they can be taken out as soon as possible. We're going to talk about dietary changes. If the patient is on a diet, are we going to change it, keep it the same? What exactly are we doing? PT/OT, which is physical therapy and occupational therapy. It's something that you have to consider on every patient, no matter what's going on. And then finally is disposition. And this is where you're going to be talking about if the patient is going to stay in your unit. Let's say if you're in ICU and the patient needs to still stay, or go to a different floor out of the ICU, or disposition in terms of discharge the patient from the hospital entirely, or to still keep the patient, and what are the reasons for it. So that's kind of where your presentation is going to end. I know that's a lot, and we talked a lot about different points, but if you keep doing this again and again and again and again every day, I think that's going to help you. That's going to help you a lot, and you're going to be able to get that down in your memory quite easily. What I would suggest, or kind of like my way of doing things, or how I did it when I was an intern, I started with something like that, similar. I actually will link the video that I learned some of these things from below, from one of the critical care attendings. It was a great video that I saw maybe like 4 years ago or so. That was helpful. But I used that video. I wrote down everything. I took the actual written kind of template with me, and I tried to fill things out. It took quite a bit of time to do in the morning. It ate up a lot of my charting time that I had. But once I did it, maybe like a week or two, I got it down in memory, and it was pretty easy to do afterwards. So I would encourage you to keep doing it and doing it and doing it. You can print the template that I have if you want, just keep it with you just for reference. I think that's completely fine. And again, listen to feedback and try to optimize things as you see fit to help you out. Why, again, just to kind of last point to leave you with, is why do I think this is really important to memorize, or at least to really get it into memory, or to be a consistent workflow that you have. Because up until this date even, I don't know what's going to happen in the future, but I believe it's going to be the same, which is, this is the same way I actually think about the patient or think about a case. This is the same way I chart on a patient. I look into all these things. If I'm admitting a case, if I'm looking at a case in the for the first time ever, or if I'm listening to a presentation, that's how I build the case into my mind. That's how I feel everybody has been doing as well. And it really helps a lot if you are organized. It organizes everything. It makes you thorough so you don't forget anything at all. And it makes your life easier, and at any level, even when you become an attending. So try to perfect that as much as possible. Try to make it your own. And I hope you guys benefited from this video. Again, please let me know if you enjoy this kind of content by leaving a thumbs up, and feel free to share it with everybody that you think might benefit from it. All the links are going to be down below. I hope to see you guys in the next one, and I hope you have a great day.